Today we're going to talk about randomized clinical trials. And these are, oftentimes they're used to evaluate a drug or a supplement, but they can also be used to randomize people to surgery or to education or to the number of gym classes they have per week. You can use randomized clinical trials for a lot of different things. It's not only for drugs. And basically, as we've gone through the course, we've kind of talked about different study designs. The way the textbook is laid out, it's kind of from the top down, but I kind of do it from the worst to the best. It's my mentality, positive thinking. So we started with ecologic study, cross-sectional studies. We went into case control studies, retrospective, prospective cohorts we talked about last week. And now we're at the most valid study design, which is experimental studies or randomized clinical trials. So at the very bottom of the list, where there's these things called case studies or case series. And I just want to bring this up because a lot of times medical professionals get confused and think of these as being like truth, but they're really not. Remember, in case studies or case series, there is no randomization. There is no comparison made with an untreatable group or a group getting some other treatment. And it's simply the observations of clinical response that doctors have noted in their patients. And it's not to say that these aren't important. Oftentimes they do generate hypotheses, but oftentimes they turn out to be false because it's really hard to get an idea of whether something is effective or not effective or if a drug is causing a certain side effect if you don't have some kind of a control to look at. But sometimes they actually turn out really good. So there was one treatment, Topamax, that's used for epilepsy. And my son has had, migraines all his life. And at a certain point, there were some people out there that were saying case series or case studies that said, migraines may be treated with this drug. And because of these case series, the drug company actually put out and did a couple of little trials and got an indication that that drug could be used to treat migraines. So they're very important, but I just want you to put them where they are and basically the bottom of the hierarchy in terms of data that we're looking at. So the problem with these case series and, case studies is really well stated here, where the professor said that results can always be improved by omitting controls. Because you don't really know. Is it the treatment you're seeing that's really, say, stopping the migraines, or is it something else that improves the outcome? And without a control, you don't know. You don't know whether it just randomly would have happened, or if it's actually true that the drug is effective or the supplement is effective. So we do want to do studies with comparisons. And in the clinical trials, sometimes there's various ways which we do use comparison groups. One of them are historical controls. These obviously are not ideal because you can't do randomization to a historical control having, some older treatment compared to a newer treatment. You could have simultaneous controls, but they weren't randomized. Like a lot of times you'll read a paper and they said, well, we took this many people and we treated them with this supplement and we just followed a control group to see what would happen without the supplement. That's different, and as we go down the bottom, we're getting a little bit better. What's ideal for a clinical trial is to do randomization, where basically it used to be a flip of a coin, but now computer programs just spit out randomization scheme. And so we do it all the time for our trials, and we basically just say, every 4 times I want you to repeat whether they get the placebo or the effective drug or the active drug. And so within 4 numbers, it'll be like 1, 2, 2, 1 or whatever. So every 4 times it's going to repeat and make sure that you have half placebo and half on the drug treatment. And then there's another thing called stratified randomization that I'm going to discuss both of these in detail as we move on. But as you get from the top of the slide down to the bottom, you're getting into a better and better scenario or study design. So historical controls is really using a comparison group from the past. It's exactly what it says in the title. You go back to records of patients with the same disease that had the prior treatment. And you can say, okay, well, what was the mortality rate if we just treated people that had coronary heart disease with drug? and now we're going to try surgery. Well, we have all this data on people that already came through that were given drug treatment. Let's see what the mortality rate was there. And now we're going to do a new study of a new surgery, and let's look at what the, say, mortality rate is there and compare the two. And that's how you would use these historical controls. So obviously, this is better than having absolutely no control, but it's not much better. You know, there still are a lot of issues that can come into play, and chance for bias, as well as has there been any changes in the population or in the way, in other ways in which, say, coronary heart disease are treated as we went forward in time from the historical controls to today's surgery evaluation. So the problems with historical controls are that there could be differences in the base population, the population basically that you start with, that you started with when you gathered the historical data or today's data. It could be that there's changes in disease rates, maybe naturally over time. I've shown you some statistics that show different cancers are going down over time, different heart disease is going down over time. Perhaps the disease definition has changed. We've talked a little bit about identification of disease based on, you know, strict criteria. And if those criteria change a little bit, remember the AIDS graph, and we're plugging along and we have AIDS, and then all of a sudden there's a spike, and it was related to a change in the definition or of the disease. There could be that there's other modes of treatment that are simultaneously changing along with whatever you want to evaluate versus a historical control. And also the quality of data collection, because the problem is that generally your current records are going to be much better than your past records. This might change a little bit with electronic medical records and things, but in the past, historical controls meant going to paper copies and trying to put together this data set that you needed. So the other, you know, the next step up from these historical controls is simultaneous non-randomized controls. And read papers very carefully and see whether they said, you know, we randomized people to the treatment versus the control group, or if they say, we followed a group forward in time that were treated with this and compared them to another group in the hospital. And notorious for this is like orthopedic journals and things. You know, they'll read papers. You read papers there, and I'm like, wow, this is really exciting. And then I really read it, and I say, wait a minute. They took one hospital, they all got treated there, and the other hospital, they did something different. And what if the hospitals have a difference between them? So be careful of what you read and see whether it talks about randomization, if it talks about the control group, if it was simultaneous, historical, or non-randomized or not. So it can be a problem if the assignment system can be predicted. So for example, if patients admitted on an even day always got the new treatment, and on the odd day admissions were the controls, people can kind of guess what's going on there, and they can say, oh, I'm worried about Mrs. Smith, I'm going to make sure she gets there on an even day, or, you know, it kind of stacks the deck in a different way. And you don't want that to happen. And without randomization, and we'll go into this in a lot of detail, the characteristics of the people will tend to be different. So just like in the case control studies and the cohort studies, when we look at that table 1, there were always differences. Once we get to a randomized trial, we're trying to eliminate those differences, but if we don't use randomization, it doesn't occur. So a clinical trial is great, but without randomization, you lose a lot of the benefit. So intervention studies are often done to test the efficacy of preventive or therapeutic measures. There's really 2 categories. You can have controlled clinical trials where the individual is actually getting the treatment, or sometimes there are community interventions. And these are oftentimes the things where they might say randomize certain communities to have the kids have gym 3 days a week instead of just 1 day a week that they have in another area. And you can randomize in that way based on the community. We talked about it with the fluoride treatment, where oftentimes one whole community would get fluoride, the other wouldn't, or maybe it would stop over time. And then there's also multi-center trials, and this is just when results from several researchers are pooled. And this can either be typically in a drug company trial where they do these efficacy studies. The landmark studies that go for the FDA approval of the drug, they will be multi-center trials. and they'll set it up at various trials. The clinical trial I'm currently planning, in the planning stage, and during this 1 year that I'm funded for, I'm supposed to decide, can I do everything I need to do at one place, Hospital for Special Surgery, where there'll be enough cases, or do I need to recruit other additional hospitals? So multi-center trials are good because it gives you more numbers, but they're also good because it increases that concept of generalizability, because you're not relying on just the patient population that would be at one center. So when we think about clinical trials, it's really a planned experiment that assesses the efficacy of a treatment. And the treatment could be a nutritional product, it could be an exercise regime, it could be a drug, it could be a lot of different things. And the outcomes in the treatment group are compared with the outcomes in an equivalent control group. And so it's kind of like that same flow design we saw with cohort study, except for now we're randomizing to whether they're getting vitamin D or they're getting a placebo, rather than, okay, these people had a lot of vitamin D in their diet and supplements and these people did not. So the participants in both groups, just like a cohort study, will be enrolled, they'll be treated, and they'll be followed over the same time period. So the really super duper gold standard trial is the randomized clinical trial. And these subjects are enrolled in the study, and the exposure, whatever you want to study, the intervention is manipulated by the investigator. In other words, when I'm in charge of my clinical trial, I am deciding that a certain number of people are going to get injections of a certain drug, and the other group are going to get injections of a placebo, and then I'm going to look at their healing rates. This is by far the most rigorous design. It gives a lot of control over every aspect of the study and over the research and the research center in general. So the subjects are basically randomized to either the intervention or the control, other times called placebo groups. And ideally, you want the investigators and the subjects to be blinded to whatever group assignment they're in. And we'll spend a while talking about blinding and how it works. And then subjects are followed up for disease outcome. Now, the important thing is, like in a cohort study, as we talked about last week, say the Framingham study or the Women's Health Initiative or something, it might go on for years, for decades, for a really long time, and they have a huge amount of people. A clinical trial is much more expensive, so you want to have that end within a shorter period of time. Typically, like the Women's Health Initiative, the clinical trial part of that was one of the longest funded studies that I've ever seen in the time that I've been doing work, and that went on about 7 years. So it's not very often that you get longer than, say, a 2 or 3 year follow-up period for these trials. And that becomes important in terms of who is going to be your study population. So here's the general schema. You start with your study population, and then they're randomly assigned to either a current treatment and a new treatment, or a supplement versus a placebo, or 2 different things, and then you follow them forward over time, and either you're looking for an improvement or not improvement in symptoms, or sometimes whether or not they get disease, if you want to see whether something helps prevent disease. So clinical trials will help to assess the efficacy of a treatment. How well does it work? You typically have to have a carefully designed and rigidly enforced protocol. And this is so important that now I had a clinical trial, I wanted to get it funded, and the National Institutes of Health said, no, we are no longer funding clinical trials, even if they're a great idea, until you have what we call a 1-year planning grant, and that's what I was funded for this year. So during this year, I have to write a rigorous protocol. I have to develop the budget. I have to do a data safety monitoring plan. I need to determine exactly how many people I think I need based on a power estimate. I have to show that I can recruit them from either one center or multiple centers. And all of this has to be done because they realize that without a really carefully designed and rigidly enforced protocol, it's not going to work. And in the past, they would fund a study, and then maybe a year and a half it would be before people really got off the ground and enrolled the first subject. So the point of this is to give funding. So they funded me, and then if I get the next phase funded, as soon as that funding comes through, I'm ready to go off, and enroll my first subject. Yes?
Is it true that sometimes you see papers that
They might. Sometimes you'll even see just a methods paper for a cohort study. Like, how did they design the cohort? I think even one of the studies I'm involved in, the GLOW study, the Global Longitudinal Assessment of Osteoporosis in Women or something, we had one paper that just kind of said, these are how we got the population. Because when you come to publish a paper, you have like very limited words that you're allowed to use. So if you wanted to give detail about all of the way in which you assembled these cohorts all over the world, it would take a lot of space. So instead you publish one paper that's basically the design paper, and then after that you can say, briefly this is what was done. For more detail, go back to that publication. So you can see some papers that simply talk about methods for a study. So there's random assignment, it's intervention and control, and oftentimes you want to give a placebo to the control group, and we'll go through some reasons why this is important. So the outcomes of the clinical trials are oftentimes referred to as the clinical endpoints. What are we looking at? Is it rates of disease? Is it rates of death? Is it recovery from symptoms or from, say, a stroke? Is that what you're looking at? Everybody had a stroke in your trial, you give them something, and you're seeing how quickly maybe they get back to ambulation or some other outcome. But the important thing is the outcome must be measured in a comparable manner in both the control and the intervention group. Otherwise, it's a problem and a bias. And so just like we talked about in case control, treating the cases and controls equally, and we talked about it in a cohort, all the different exposure groups should be looked at equally. It's the same thing with the clinical trial. So some of the examples of clinical trials is the Medical Research Council did a vitamin study. They looked at the role of folic acid in preventing neural tube defects. And because of this, a lot of breads and things now have fortification with this. In the South Bronx, there was a sexually transmitted disease program. They looked at the effectiveness of education to prevent the spread of sexually transmitted diseases. So just to give you two totally randomly different designs, but they're both clinical trials. So here's a schematic example. So we wanted to know whether vitamin X would help to reduce high serum cholesterol. So you start out with your sample, and just like when we're talking about a cohort, you have to think carefully about who that sample is going to be. Then you randomize them, and they either get vitamin X or they get a placebo. You follow them over time, and then you look at who developed hyperlipidemia versus who did not. And so that's like the general idea of how you would go forward in time with the clinical trial. So clinical trials are used a lot for evaluating new drugs and other treatments like nutritional supplements. Drugs have to get approved by the FDA, and they won't be approved without a series of studies showing efficacy and safety. Nutritional supplements are a little easier. They don't have the same rigor in terms of control over them, but sometimes if people want to make advertising claims with their supplements, they might want to make sure that they've done some studies to show that the supplement actually is beneficial. Yes?
Does the FDA regulate the claims that they make?
It's the FTC, like the Federal Trade Commission, or, they're in charge of making sure marketing is not saying falsehoods.
I worked for Pfizer last summer in their nutritional supplements department, and things that they were putting on there were very interesting.
Yeah, no, they're very interesting, and they have to cross a fine line. Like, they're not allowed to say that they stop a disease, but they can use something that's associated with the disease. So you can't say, say it stops osteoporosis, but you can say it might help your bone health. And so it's very crafted wordsmithing in order to make sure that you don't cross a line that's not legal or right. And the last one that I remember that got in trouble was, I think, a calcium supplement, and it might have been from like shells, oyster shells or something, and they made certain claims that were way above and beyond what they could, and so their ads quickly got squashed. So it's a whole different evaluation of these products, and there's different categories and there's different rigor with which you have to show that they're safe. But the general thing for supplements is they have to pass this generally regarded as safe criteria. And once they do that, then they kind of can be on the market. but you have to be careful what you say about it. And also, clinical trials are used to assess new medical technology, so whether it's a new way of diagnosing something or a new way of surgically treating something, you can use a clinical trial for that, a randomized clinical trial. And when we get to the screening lecture, some of the data that I'm going to show you on mammography and lung cancer and things like that in terms of screening programs were based on randomized controlled trials to show whether or not it's efficacious to actually do mammography in younger women. And same thing with hemoglobin A1C. Like there were studies to see whether that would be a better marker than just looking at serum blood glucose. So randomized clinical trials have a lot of advantages. There is not selection bias, and you'll understand that more when we get through randomization. There's certainty about exposure, although compliance should be monitored. So I can tell, half of you to take vitamin D because you were randomized to it, and the other half to take placebo. But you vitamin D group is not necessarily going to take the pills that I give you. And that's what compliance is all about. So you can have a great design study, but if the people don't comply for whatever reason, there's an issue. And early trials of trying to lower blood cholesterol before all the statins and everything were using like junk that you poured into a liquid and stir it up, and it tasted horrible. And so they did clinical trials of it, but the problem was compliance was horrible because people just didn't like the product. And so you have to think about compliance when you're designing your study, and for what reason are people going to want to stay with the program and take the treatment. But these randomized clinical trials are typically the gold standard. But there are limitations. Typically, it's also the most expensive clinical trial. They can be lengthy. As I said, they're at least usually a few years. Sometimes they can be shorter if there's some intermediate outcomes. And sometimes you're suffering from a lack of generalizability, because when you think about that population you're starting with, you want them to be at risk for getting disease in a couple of years, or else how are you going to evaluate whether or not the treatment stops disease? And because of that, you might be selecting a higher risk population in order to make sure that they're more likely to get disease. Did you have a question? Yeah.
Yeah, could you explain how many other studies would have better generalizability?
So some of the other studies would have better generalizability, say a cohort study, because you start with Framingham and you start with all the people that live there. Or you start with all people that got a nursing degree. So they're typically larger, and they cover a broader area, and they're not chosen to be at risk for the disease typically. They're chosen because they're healthy and they don't have the disease. But when you get to a clinical trial, a lot of times they will do something to make sure the population is at risk for the disease. So I'm going to talk in a little while about a tamoxifen study, and that was to stop breast cancer. But in order to test that, they didn't want to just take all random people and do it, but they took people that were higher risk of breast cancer. And there's a thing called a Gale score where you put it like certain characteristics in family history and stuff, and you see if you're at higher risk. So they chose higher risk people to be in that study. And so then when you go to generalize the results, all you can talk about is that this will stop, say, breast cancer in high-risk women, not the general population. So there's also sometimes ethical issues, and these are usually, stopped because people go through institutional review boards, which some of you will get used to because of if you're working on a clinical trial for your thesis. But usually, the ethical issues are not a big deal, except for when you're now getting to the point where a lot of diseases have effective treatments. So we always used to do placebo-controlled trials, and now that we know there's effective treatments, is it really ethical to not give people a treatment? Should we be comparing a drug versus a gold standard? But that makes the study much more expensive. So there's some issues that we'll talk about in a little while. So these are the ideal components of a randomized clinical trial, that you have concurrent controls, that at the same time you're randomizing people to treatment, you're randomizing them to a control group, that there is randomization, that you do use placebos, and that there is a double-blind technique. And all of these things are very important, and what they all manage to do is to increase the validity of the study. So all those threats, things like confounding and stuff, are better controlled if your clinical trial has all four of these components. So when we do a clinical trial, just like when we talked about a cohort study, the first thing we're thinking about is the selection of subjects. So usually the investigators have a clear criteria of who will be in the study. For me, the clinical trial I'm planning, it's very easy because I want to see if I can more quickly heal pelvic fractures. So my people all have to have pelvic fractures. In other clinical trials we've done, they all had to be, say, postmenopausal women who maybe were having symptoms of menopause. There's other trials, you know, depending on what you want to get at, your population will be chosen accordingly. We have another study that we're doing where everybody is having an elective total hip replacement, and that is our population. So you have to think about who your population is and have clear criteria about who will be in the study. And this is also for safety's sake. So when you put in a trial, they're going to say, well, you know what, there might be a higher risk of whatever treatment you're doing for X, Y, or Z people if they're on this drug or if they have this medical history. So you need to exclude all of them. But the thing is that whoever you exclude is excluded both from the control group and the treatment group. So you have to have criteria written in advance for inclusion and exclusion criteria and have them apply to all groups. And all of this will impact on the generalizability because the more people that you're excluding, the more likely you are that you have to then basically summarize your data in relation to that very narrow group instead of the general population. So here is a trial where a vaccine was given to those who they believed would be more compliant. So BCG was used to prevent tuberculosis. So this was a trial looking at vaccinated people versus control people. So what do you see here? Does the vaccination appear to work in terms of the number of tuberculosis deaths that you see with the treatment? Right, they're lower, right? It's 0.67% versus 3.3%. So there does appear to be a difference between the people that were vaccinated and the controls. So remember, I told you that these people were given the vaccine if they were believed to be compliant. So what is the concern there? Not everybody in the study was compliant, but the ones given the active treatment were compliant. And what would be one of your concerns? Yeah.
Some are compliant in other measures that make them not get tuberculosis.
Right, they might be in general more healthy and in a way that they're not going to get tuberculosis. So yes, they were compliant with this treatment, but they probably also maybe had a difference in exercise, had a difference in, you know, all other kind of health behaviors. So in fact, what happened is that they did another trial of the same drug, but this time they did random assignment. So they didn't just give the treatment to the compliant group and the controls were the people that weren't so compliant. And look what happens here. You had hardly any difference. So there was no significant difference once you added that randomization. So it kind of points to the idea that there was a difference between those compliant people and the non-compliant that made BCG look good, when in reality, if you randomize, get rid of that compliance factor, there no longer is any difference. And that's why I want you to read carefully when you're looking at a study and see, was there randomization, or by some way was the treatment chosen for some people and not for others? So why do we randomize? We basically want to prevent investigator-patient bias. So you don't want the investigator either saying these people are compliant, I'm going to give it to them, or this person is sicker, so I'm going to give it to them. You want people to have equal odds of getting the treatment or getting the placebo when they enter the study. You also want to establish balance at baseline in terms of potential confounders. And what that means is that when we look at our table 1, which up until now has always had significant differences, we would hope that with a randomized controlled trial, you now will not have any differences between your placebo and your treated group. And so that's the balance we're looking for. And also, certain statistics that we use rely on the fact that we say that the people were priorly randomized. So certain statistics that we used are based on the concept that people will be randomized in advance. But there are randomization issues. You know, nothing is perfect. So in some subjects, they leave the study because of a certain characteristic, say that they're an older age to a greater extent in the intervention or control groups. And then you lose the benefits of randomization. So just like we talked about in the cohort study, where if people dropped out of the study in those 4 different cells, A, B, C, or D, it could have an impact on the results. It's no different if we're talking about a randomized trial. They might have started out even, but if you base your results on who is left in the trial at the end, then that will be based on no longer even characteristics between the groups. It's also possible that one or both arms of the study will not be compliant with the group assignment, the intervention or control, and that would lead to an underestimate of effectiveness. So for example, if the intervention was exercise, you might have people that were randomized to exercise, but they don't feel like exercising, so they just don't do it even though they were told to. And then you have a control group that read a paper and it said exercise is going to make you live longer, so they start even though they're in the control group. And these are things that it's really hard to control. So I just want to illustrate some of this. So, well, first, the major goal of randomization is really to increase the probability that there's an even distribution of observable and unobservable potential confounders between the intervention and control groups. So what that means is not only table 1 variables will all presumably be the same between the treatment and the control group, but also things that maybe you hadn't thought about to even ask will also probably even out. So even though there's a risk factor you didn't know about until after your study was published, chances are it's taken care of with randomization. Whereas if you're doing matching or something like that, you can't really match on something that you don't know is going to be a potential confounder later. So here's an observational study on the left side. And these boxes are either white, which means that people didn't have arrhythmia, or they're pink to say that they did have arrhythmia. And so the observational study, they started with 2,000 people, and 1,300 of them without arrhythmia, because this is the white part, were sent towards intervention. About 800 of them ended up not having an arrhythmia. And on this side, they had no intervention, and you have more of the people that actually had arrhythmia ended up in the no intervention thing. So we already know that there's a difference in the case fatality between arrhythmia or not. And so what is that going to do to the results? When you follow it forward in time and you look at the number of deaths, the case fatality rate is 18% for the intervention and 30% for those in the control or the no intervention group. So it looks as though this treatment is really beneficial. It almost cut the rates in half in terms of the case fatality or the deaths due to arrhythmia. But what is the problem? What happened is that when we randomized these people, they ended up with an uneven distribution between those that have arrhythmia and those that did not. And that could very easily lead to the results. So if instead we do an experimental study and we randomize people, and we randomize the people that are from the intervention, they're going to be even number of people with and without arrhythmia in the 2 groups. By doing randomization, that's what's going to happen. They're going to end up evening out. And once you even out the background risk of these people, you can see that even with the intervention, it still is a 24% case fatality as it is with the people without intervention. So if you randomize, you get rid of what appeared to be a beneficial effect of this intervention because now you've evened out the background arrhythmia in these populations. So is that clear? So you can randomize a whole group, or you can use something that's called stratified randomization. So in this case, they wanted to stratify by both sex and by age to make sure that there will be even numbers of people, male, young and old, and female, young and old, in both groups, the current treatment or the new treatment. So they started out with 1,000 people. There were 600 males, 360 were young, 240 were old. They take this bottom box and then randomize that to new treatment or to current treatment. So that's where this 180 here and the 180 here came from. And across the board, they used these lower 4 boxes in order to split at that point into the randomization of current treatment or no treatment. And that way, in the end, we end up with 500 males, 500 females, and they'll be evenly distributed between young and old as well. And so this stratified randomization works, and we do this in a lot of our studies. And when you do that, you end up having different randomization lists, so that in this case, you would have 4 different randomization lists. So these people, I would have a list of, say, 50, and they either get the drug or the new treatment or the current treatment. And then the same thing for each of these boxes, I would basically have a randomization list. And that takes care of age as well as gender by stratifying the randomization. You make sure that you're going to have even numbers, because even though randomization should make it even between the 2 groups, it's not always going to work to make sure that these strata are also even between the groups. Did you have a question?
Did you say that this was the best kind of randomization?
It's a little bit better. It's not essential to do it, but if age and gender are pretty strong risk factors, then you want to make sure that you get an even distribution.
Is this common? Because I feel like I've never, I don't know, I don't really see this in studies where they say we did stratified.
You wouldn't see it except for in the methods where they say randomization.
But do they say stratified, or do they say it a different
They
way?
might have said it was randomized by groups.
Okay, so it might be
Yeah, so it might be that it's there, but just using different language. And it's, I guess it depends on the size of the study. If you have a huge study, this is not going to really matter. But our one where we're looking at people that have total hip replacement, and we're only randomizing 50 people, and they're going to be obviously males and females all have, hip replacement, and they're going to be, anything from 60 to 90 years of age. You want to make sure that you at least control for something. So in that one, we control just for gender, male and female. And, our study design with only 50 obviously isn't to look at a treatment. What we were looking at is like mechanisms of action at the skeletal level, like taking the hip and then harvesting it and looking at what happens to the cells with treatment or without. So, you can use a smaller sample size like that, but if there is a difference between men and women, it might have gotten lost if somehow our randomization didn't work for the smaller numbers. So blinding and placebo are used really to ensure that neither the study subject or those assigning the outcome are aware of the group assignment. And this can oftentimes help decrease bias. If the person that you're giving the pill to knows that they're on a treatment versus a placebo, they might report different findings of how they feel and, whether they had colds if you were giving them vitamin C or not. They might just report different data if they actually know what they're taking. And the same thing with the investigator, who oftentimes is looking for the outcome or disease. You don't want them to look harder because they know that a certain person was given the treatment that they're evaluating and hope will work. But blinding is also called masking. And this maintains the integrity of the study, and it reduces the potential for bias. So the investigator can use one of 2 different things. It could be a single blind design, in which case the subject is the only one who's unaware of the group assignment. So they're given something, they don't know what they're given, but the investigator knows. And this is a fine method if whatever outcomes you're assessing are very objective. Once there's any subjectivity in the outcome evaluation, you want to make sure you use double-blind assignment. Because in that one, neither the subject nor the person doing the experiment is aware of what the group assignment is. And that is really the gold standard. And so it's just shown here. Dr. Burns, are you sure this is what the statisticians call a double-blind experiment? So, this is a joke, but in reality, there really are a lot of layers of safety to make sure that the subjects aren't hurt. So although there's placebo and not, if in any of our trials someone ends up in the hospital and it might matter to know what treatment they're on, they get unblinded. There's always like a data safety monitoring board which looks at the outcomes in both the group A and group B. They don't know which is which, but if they start seeing a huge difference, they might start to ask more questions. The institutional review board also makes sure that it's safe, that someone getting a placebo isn't going to be harmed. So why do we use a placebo in the control group? So we talked a little bit about blinding. Now let's talk a little bit about the placebo. The placebo effect exists, and the rates can really vary. And one of the examples is that in hot flash diaries, people before the study started said that they had like 35% of the time they were suffering hot flashes. As soon as the study began, they said 0%. And yet they were on placebo. So there is such a thing as the placebo effect. And just being on a study can sometimes make people feel like something's happening. It may also help to control crossover, and we'll talk about that in a little bit, but that was like the example I talked about with the exercise, where you might randomize people to exercise or not, but they might change their mind and either stop exercising or start exercising. But if people get placebo, they don't really know what they're taking, and so it's hard for them to actually report this placebo effect because they don't know if they're on the active drug or the placebo. But even with a placebo, a lot of people will guess treatment. And we had this. We were trying to compare 4 different drugs, estrogen, tamoxifen, raloxifene, and placebo, in a group of postmenopausal women. And it was a small study because we were looking at, we would do like EDTA infusions and, just do different like clinical tests that would change their whole metabolism and then see how they responded based on these drugs. So we had them on each of these drugs, and we're like, okay, this is great. We got all the drugs. We bought them. We brought them to our pharmacist, and we said, put these all in the gel cap so that no one will know what they're taking. And that's great, but a lot of the women opened that capsule and then looked and said, oh, it says I'm taking estrogen. So sometimes they will know the treatment because they kind of get rid of your, way of trying to disguise it. And other times they're going to guess their treatment. So, for example, in this trial, women that were on estrogen had things like breast tenderness and stuff that are known in that drug and not in other drugs. So, sometimes people will guess what their treatment is. And this is actually shown here, where this is a trial of vitamin C and placebo looking at the common cold as the outcome. So this was simply a questionnaire that tried to determine whether the people knew, do you think you're taking vitamin C or do you think you're taking placebo? So the actual drug is shown here, vitamin C and placebo, and this is what the subjects suspected they were taking. So if you look at vitamin C, 40 out of 52 people suspected that they were taking vitamin C. And the problem with this is that there hadn't been anything done to try and get rid of the fact that that had an acidic taste, whereas the placebo basically had no taste. So you have to think about these things, and you want to try and prevent them from happening, but you don't know they're going to happen until after you start, and then people, tell you what had happened. So, yes?
Do you ever try, to cause the placebo to have side effects so that it's more indicative of having the drug?
No, not typically. Typically, you have to say that, you're trying to treat them safely and fairly, so you wouldn't want to, make the placebo cause more effects. But I'll go through some data in a little while where even if you're giving someone a placebo, people get sick. And so it's really hard to, you're going to get illness anyway in the placebo group. So you don't really need to do that in general. Is there another question over there? Okay, so the placebo group is often important to study side effects. This is actually the slide I was talking about. So if you did not have a placebo group here, these were people that were given aspirin or placebo, and look at the GI symptoms. So if you only had the aspirin group, you might think, wow, aspirin is really bad. About 35% of the people end up with GI symptoms. But in reality, by having that placebo group, we can see that actually that's the rates that normally occur in people. There's absolutely no difference in the rates of GI effects. Now, bleeding problems was different, but the whole point here is just I want to make is that you need this control group even to evaluate safety, because you might falsely think that there's some side effect from your treatment when really you just have no concept of how many people complain, say, about GI symptoms. So there's certain data that you want to make sure is collected during the course of a randomized trial. And you also want to see it when you're reading a paper that's a clinical trial. So the first thing is regarding the treatment. What was the assignment? How was it done? Was it done by randomization? And what was the compliance? In other words, how many people actually took the drug that you were given? And this is done in a lot of ways. We do it through pill counts when we give people pills. So when I did a vitamin D supplementation trial, I got vitamin D or placebo in gel caps. And every month they'd have to bring back their bottle, and we just count how many pills are left. And that's one way of getting compliance, is pill counts. There's another drug that we use that's a self-injection each day. And so when the people bring back their pen that's good for a month, we weigh it and see did they take it every day or how many doses are left. There's also self-report. You just ask people how many times did you keep it. Oftentimes we'll have them keep a diary, especially with the self-injection, and that helps make sure that we really can monitor it well. And sometimes you can measure something like the vitamin D was really easy because besides counting the pills, I also had the capability to see if their vitamin D levels went up in the vitamin D group and didn't change in the placebo, and that was the case. So I felt like I had good compliance, just like my reports had said it was like 85%. Yes?
If you're measuring compliance mostly just by pill count, do you think, or do you ever see that people lie or throw out pills they take or something, or is it mostly true?
They probably could do that, but a lot of times whoever you get into a clinical trial is in the trial because they want to see if it makes a difference. And if they understand that, they kind of understand that part of that is the compliance and us understanding that they weren't compliant. Because, you can look at the data and take out the non-compliant people and see what it looks like. And I'll talk about the problems and issues associated with that. But it gives you a better idea. And the other thing that's really important is you think it's important just to see your own study. But in reality, if you have a drug and you're developing it and your compliance rates are like 60%, then you might think twice about that drug, that maybe you need to change something about it so that when it goes out to market, compliance will be a little bit better. So people could lie, but you're kind of hoping that they will not. But you always kind of hope to have a backup way of telling as well. And we oftentimes have measures in the blood that we can do that will give us kind of an idea, like that if you take this drug, this will happen to this biochemistry test, and you can assess that as well for a more objective thing. Yeah?
What's the lowest accepted percentage of compliance?
That's a good question, and I wish it was somewhere around 75. That's what we believe is good enough. But I have seen papers published where it goes down to like 50%, particularly by the end of the study. And so, there is probably a gold standard that's somewhere around 75 to 80 is what you want to see, but that doesn't mean you won't see studies published that are way down lower than that. Okay, and then the outcome, you want to look at measures of both drug efficacy as well as side effects, and we talked a little bit about that. And for this, you really want to have strict criteria for what you're going to call an incident, and also blinding is going to be very helpful here to make sure that there's no bias in what's reported either by the subject or identified by the investigator. And you also want to compare the entry characteristics to determine if randomization was successful. So how would you do this? In your two papers you got today, how would you look at the last bullet? Yeah.
You would see if age and sex was evenly distributed.
Right, all the variables in Table 1, you really hope that they're going to be pretty even if, in fact, your randomization was successful. That's part of the point of randomization. And when we get into our confounding lecture, we'll talk about the logistics of why that really works. So the outcomes of clinical trials are referred to as clinical endpoints. They can include rates of disease, death, or recovery. And importantly, you want to make sure that they're measured comparably in both the intervention and in the control group when you're doing a clinical trial. One of the other important concepts in clinical trials is this concept of intention to treat analysis. And intention to treat analysis is really a conservative way, and by conservative what I mean is that it's less likely to show a benefit of assessing the intervention because we know that the true intervention effect is really diluted by crossovers. The people that were randomized to something but didn't take it, weren't compliant, or switched to the other group. And if the data was not analyzed this way, it really violates the randomization process and leads to confounding. So I asked you on the last slide, how do you know that randomization worked? Well, Table 1 is equal. Okay, great, so randomization worked. But now if you only take a pocket full of people from, the intervention group and another smaller group from the control, is that still valid? Will the randomization effect still be true? Chances are not. And that's a problem because if you were looking at exercise intervention, and you said, okay, I'm only going to look at the people that really stuck with it as compared to the people that were in the control group. Well, that's not really valid because that's no different than a cohort study because the people that are going to stick with the exercise are probably health conscious in general, and you're going to be comparing them to non-healthy people just like a cohort study. And that is why when you do randomization, you do it and you stick with it all the way to the end to this intention to treat. And we'll go through that in a little bit more detail. So cumulative incidence we talked about last week, but it's really the proportion of subjects who develop the disease over the follow-up period of the study, or the average probability that a person in a randomized control trial will develop the disease during the follow-up. And just like we used in the cohort study incidence rates, we also use incidence rates in in randomized controlled trials as well. So let me just give you an example of this. This was a trial that was published in the New England Journal a while ago, maybe like 10 years ago, but it was a calcium and vitamin D trial with looking at fracture as the clinical endpoint. So people were given 3 years of calcium, 500 milligrams, and vitamin D, 700 international units of vitamin D3 or cholecalciferol per day, or placebo. It was 176 men and 213 women that all had to be living at home. In other words, it wasn't nursing home populations, and they were all over the age of 65. The outcomes that they looked at were bone density, biochemistry, and fracture. And when you read the paper and you look at how they did the analysis, you want to typically see that they did an intention to treat analysis, particularly when, as in this case, the dropout rate was about 25%. So the results that were published look like this. So this here is the incidence, cumulative incidence of fractures in the placebo group versus the calcium and vitamin D group. So in the placebo group, it was about 12.9% of the people ended up fracturing, or about 26 of the 202 people in this group. And the calcium and vitamin D was about 5.9%, or 11 out of 187 people in that group. So what we could say, comparing 12.9 to 5.9, is that calcium and vitamin D basically decreased the fracture rate by about 45%. So you can see just graphically what that looked like, and this might be the typical presentation in a randomized controlled trial. The statistics that we do are very similar to what we do in cohort studies. So the same concepts I talked about last week that are important in cohort studies are also important in randomized controlled trials. We hope that we'll get more people to stay in the trial And it's very important to do this because you have a lot of money invested. That randomization is important, so you want more people to finish the trial and be able to have all the people that were randomized actually complete this study. But because just like in cohort studies, people will drop out or they might die or something might happen, we tend to use different analysis, something like survival analysis or product limit analysis. And this is equivalent to 1 minus the probability of not developing the disease at any time interval. And the statistics you might see are just like we saw for cohort studies, things like Kaplan-Meier or Cox proportional hazards model. And just like if we were doing a cohort study to look at the degree of the association, how well does the treatment relate to fracture, and the last thing, the calcium and vitamin D versus fracture, we can use a risk ratio. That would be the cumulative incidence in the intervention divided by the cumulative incidence in the control group. So if we get a risk ratio of 0.5, it says that the risk of disease in the intervention is half that of the controls. So in other words, whatever your treatment is you're testing is preventing half of the disease. And just like when we talked about last week with cohort, a relative risk of 1 means that there's no increase in the risk of disease. If it's less than 1, it appears to be protective. And in general, when we do randomized control trials, that's what we're looking for. We don't typically randomize people to something we think is going to hurt them. So usually you are looking for a relative risk less than 1. If it's greater than 1, it means the exposure increases the risk of disease. And remember, when we talked about it last week, it's the same thing. The risk ratio is a relative measure. It's not an absolute measure. It's not telling you, the rate of disease in one group versus the other. So this graphic here is the study I referred to a little bit earlier. It was a study looking at breast cancer prevention using tamoxifen in over 13,000 women. So they had used tamoxifen in women that already had breast cancer, and they found that there was a decrease in secondary occurrence, in other words, getting cancer in the other breast. So the study was planned to say, well, if it works for that, maybe it would stop the first breast cancer from occurring. So in order to do that, they did this large clinical trial, and people were randomized to either placebo or tamoxifen. And this graphic shows the placebo in these white boxes versus tamoxifen here in terms of the cumulative rate of both invasive cancer and non-invasive cancer. So in this trial, they tried to make it a smaller sample, like the 13,000 women that they would have needed as compared to if they just let everyone in the study, by making sure that the inclusion criteria was women that were at high risk for breast cancer. So that was the Gale score I talked about before. So anyone that scored higher on the Gale score and was more likely to be at risk for breast cancer, they either had a family history or maybe they had some kind of fibrous breast disease before, or some kind of risk factors that made them at higher risk allowed them to get into this trial. So in this trial, they showed a 45% reduction in the risk of breast cancer. But remember that when you report these results, it has to be in high-risk women, and that's the generalizability factor. So you do see a 45% reduction, but we don't know if it would work in low-risk people because we did the study in high-risk people. So in general, this showed that you could see a pretty good reduction in invasive breast cancer over the course of 6 years by giving people the tamoxifen as compared to the placebo. However, whenever you do a study like this, it's important to see the efficacy. How did it do on the outcome we planned, the breast cancer? But that's not enough. We also want to have a concept, is it safe? We don't want to trade off, stopping breast cancer for something else. And so, in fact, one of the things that they found is that there was an increase in endometrial cancer with tamoxifen. So this was just in the same 6 years looking at side effects over time, and that's why it's got to be very carefully collected. They noted that the rates of endometrial cancer were actually higher in the women that took tamoxifen as compared to the people that took placebo. So although there was a benefit for breast cancer, there was a small increase in the risk of endometrial cancer, and that changes the benefit-risk ratio. And that is why careful collection of all data, not only your primary outcome, is very important for these kind of studies, because you want to make sure not only that efficacy is there, but also safety. So just a couple of other examples of studies. This one was looking at oral vitamin D3, 1,200 international units a day, which is shown in the black bar here, versus placebo in the white bar, was given over 4 months to 334 school children that had asthma to see what proportion would end up with asthma attacks during the follow-up period. So you have vitamin D or placebo as your treatment group, and that's what they're randomized to, either one. And then the outcome is what proportion had an asthma attack. And you can see here that the relative risk was 0.17. Again, we're giving something to someone. We want to hope that it's protective. So it's reducing by about 83% the rate of asthma attacks in people that took D3, in children that took D3 compared to placebo. So again, the results here, generalizability. It's school children 6 to 15 years of age with asthma. We can see a dramatic reduction in the rates of asthma attacks that occur in people that take vitamin D as compared to placebo. So there was one other study that looked at the impact of oral vitamin D3. Again, 1,200 international units a day versus the placebo. 4 months still, and same ages, 6 to 15 years of age. But now they were looking not at children with asthma, but all children, and looking at the rates or the proportion that develop influenza A. And you can see here that, again, vitamin D3 is here, placebo is here, the relative risk is 0.58. So there was a 42% reduction in flu with people given the vitamin D versus the placebo. So these two trials were pretty compelling, and at the same time here at Columbia, we had already developed a study where we were looking at vitamin D. It says future study, but it's almost done. The vitamin D has basically potent antimicrobial and immunomodulatory properties. And we thought that perhaps children that have sickle cell anemia might, and one of the major complications is respiratory disease. So we gave them vitamin D to see whether or not we could reduce the rate of respiratory complications in these children. And based on the results of these two studies, we felt that we were pretty confident that at least there probably wouldn't be risk, and perhaps there was a potential for benefit. And so we're doing a randomized controlled double-blind study looking at the efficacy. We're giving it monthly. Vitamin D, since it's fat soluble, you don't have to give daily doses, so we're doing it monthly. 100,000 international units compared to 12,000 international units. So it's 400 international units a day versus 3,000 a day. And we're looking at this in 80 children and adolescents with sickle cell disease to see what kind of effects we can get and whether or not it will actually help prevent sickle cell anemia from occurring. I mean, not sickle cell, but respiratory complications in sickle cell kids. So if you want, why don't you take a 10-minute break, come back at 20 after, and then we'll go on with the lecture, do the papers, and then you'll do your group exercise.
So the one, oh, can I point it out here?
Which one?
The children one. So this one was done with children with asthma,
right.
And this one was without, but it's looking at the
Flu.
The flu. Okay, I just wanted
Yeah, so this outcome was asthma attacks, and this was flu. And this started out with children with asthma, and then this started out with children that were just generally healthy.
And then the reason why was because of the relative risk, or what was the reason why they would choose children with asthma?
Well, because the outcome was asthma attacks.
And then what was the thing about relative risk where they
Okay, so
want-
relative risk is 0.17. That's equal to the difference between this and 1 is 8.83, so it's an 83% reduction. And then the same thing here. If you have a relative risk of 0.58, it's a 42% reduction.
And then previously you said they aim to have it lower than 1, meaning
Well, because if you're doing a clinical trial, you want to make sure whatever you're giving people and making them take is going to help them.
but don't you not know until you do the actual
You don't know, but you
test?
don't want it to be causing risk. So in other words, I wouldn't randomize people to smoke cigarettes or
Right.
not.
Okay,
Because
so
that's
it's
a
based
risk
on
factor.
general
Based on general knowledge. So in
knowledge,
other words,
okay.
because these two showed a protective effect, we feel like we can do this in sickle cell kids.
Okay.
But without having some indication that there might be some reason for benefit, that we're not just shooting in the dark.
Okay, all right. That
So you
makes-
have to show like some kind of backup data that says this makes sense.
This is okay because we see.
Right.
Okay, okay.
And there was no reason to think it will be, cause any risks. Because if you look at trials like this that have already been published, there's been very few side effects or any risk associated
Right.
with it.
Okay. Okay, that makes sense. I was like, how do we know if it's lower? Okay.
Yeah.
Okay. Thank you.
Okay.
How are you?
Okay.
A gloomy day.
I know. My foot keeps spasming so
Oh
much.
no! That's like
It's what?
that's the worst feeling.
Yeah. It's almost like a Charlie horse.
Yeah.
No, that makes sense. You're gonna get squashed today.
Yeah.
You don't have exams. I mean, did you plan ahead of time? But sometimes I do. Sometimes I don't. I want you to make sure. Oh God, is that not the greatest exception?
They have so what'll happen is like there'll be one central site called the Charlie study, and from there they'll tell you, this person gets a placebo, and then you call them up later and they say, well, this is they're not telling you, but they say, use this, package or use that package that's in their treatment. It is a clinical trial and it will typically be randomized as well. And if it is randomized, that's usually done, like I said, at one center. And then they'll tell you, whether your person, which basically they give you blank packages that have numbers on them. And they know what's placebo and what's not. Once they give them package ones who are free, and then it's double blinded because they're all the way out, like in some, say in California, and they're calling us, telling us to take this package. We don't know what's in the package. We get into the subject doesn't know what's in the package. So that's where the blinding is. There's always one person that knows, because otherwise someone has to make the randomization.
So people who value the trial knows.
Well, like in our team, I'm usually the person that knows because I don't see the patients. Like our nurses won't know, our doctors won't know, but because I actually don't see the patients, I will create a randomization scheme and I'll randomize people and I'll give them the product and I'll know what it is, but I'll know what it does. So like we did 100,000 international units a month. So instead of, giving the daily number to 50,000 a day, but if we gave 3,000 a day to kids, we're worried they wouldn't always take it. So by giving them one dose of 1,200 when they're right there in front of us, we know they can cover for the month. No, they take it when they come into the center. They get either 100,000 one pill or they get a 1,200,000. No, and that's what they had to show in the application. There's no toxicity.
I'm hoping that
Yes. Okay. By Wednesday. like the prostate cancer as the outcome. It could be that one was positive and one was negative for prostate cancer, but they both have to be measuring the same outcome and the same exposure, and those are different designs. Yeah, vitamin, tell me what the difference is. Will you take a vitamin D capsule once a month, or did they ask for more than that?
Sorry.
Yeah.
Hi, I have a quick question for you. So I got a med school interview in November, and it's the day of during one of your classes. So would you like me to email you?
It's the date.
It's November 13th, so it's a Wednesday, so I
Okay.
won't be able to attend
So
class.
you have to forward me the invitation.
Okay, no
That's
problem.
what you do, and then I just report it for that day.
All right, perfect.
So it's an excused absence as long as I get it in advance and then it has that.
Got it, perfect. I'll email you to you
All
right
right.
now. Thank you.
All right. Yeah.
So I have a question about randomization and
Okay.
compliance. So I've seen some studies give the whole group placebo for like a month or 3 months and exclude those who aren't compliant.
Right.
Now, would that affect the study at all? Would that strengthen it or weaken it? If they
Well,
exclude
it'll
them?
probably strengthen it because then, a lot of what you're worried about is who's going to finish the study and
Right.
who's going to be compliant. So in an ideal world, you have 100% of your population finish the study and 100% compliance in both the placebo and the active group.
Okay.
And so by getting rid of the people that obviously aren't compliant, they probably wouldn't get any better as time went on.
Right. Yeah.
And so you end up with a better group. And you don't know whether they're going to be in the control group or, the placebo group or the treatment group, the
Yeah.
ones that stay in.
Right.
And so that'll be fine. You won't ruin the randomization or anything. So
So
they're
they-
not
I
randomized
see,
until
they did
after
it.
that.
Yeah, okay.
So it's like a lead-in study where they just say, okay, I'm going to get rid of 10 subjects because they only were 20% compliant or whatever.
Okay.
And then you do the randomization
I
of the
see.
remaining 90 that you might
Yeah.
have left.
Okay, that makes sense.
Yeah,
And
so it
is
wouldn't
that
ruin
common? Is that like a standard?
It's not a standard, but it's not uncommon. So, I've seen it before in a
Yeah.
few studies. I've never done it.
Uh-huh.
But I think if you have an investment of a long-term trial, like a lot of the trials we do are 3 months, 6 weeks, or, they're very short-term because we're looking at physiologic outcomes instead of disease. But if you want to give someone something for 3 years or 8 years, you want to make sure that they're going to stick with the program. And so then it's worth it because in the end you get better results.
Okay. All right. Thank you.
And better results, I just mean they're more valid because
Yeah.
you have more people finishing and more compliant.
Okay. That makes sense.
If we could get started. Hi.
Is it okay if I send it to you from my other email? Because I get it to my, I don't have it on my Columbia email.
That's all right.
All
So
right.
just JWN5.
All right, perfect. Yeah.
Okay, so we're going to talk about We're going to talk about power and sample size now. This is particularly an important issue in randomized controlled trials because, like I said, they can be very expensive. And so you want to make sure that you are doing a trial that's likely to find something if there is something to be found. So the larger the sample size of a study is, the more likely you're going to see an intervention and disease association, given that one really exists. So the power of a study is the probability of finding a statistically significant association in the data, given that the association really exists in the population, in the study population. So this table kind of helps understand what's going on with the power. So you make a decision basically based on the data you have. What did you find in your study? Either you found the treatments are not different or that the treatments were different. And in reality, we don't usually know this, but given that, say we knew that in reality the treatments are not different or they are different, these are the 4 different things that can come up. So you can make a correct decision, and that's great. You can make a type 1 error, and that's the probability equals alpha. And what is it we usually set this as in most papers? What is that? Yeah, 5%, like P of 0.05. Then you can have a type 2 error, which is that you conclude that the treatments are not different when really they are. We don't really want that to happen too much because then, we're not really finding something that's maybe important to be found. And then we have a correct decision here, which is where we get the power or the probability of 1 minus beta. And in general, you want this to be somewhere between 80 and 90% minimum. So if you write a grant and you don't say that you have power or that you think your power is somewhere around 80 to 90%, you're not going to get funded. Ideally, I don't think I've ever put in a grant where I didn't say I had at least 90% power based on the data. Because if I could do it at the cost, it's all a cost thing. How much money are you going to ask for in the grant, and are they going to be willing to give? And how many people do you need, and can you do them for that cost? So this is kind of the different things that can happen with a study design. And there's some terms that I want you to be kind of familiar with that were in this table, but they're just spelled out here. Alpha, the probability of making a type 1 error or concluding the treatments differ when they really do not. And beta is a type 2 error, and that's concluding the treatments do not differ when in reality they do differ. And then power is really 1 minus the type 2 error, or 1 minus beta. And this is what we really want to increase before we start the trial based on the sample size we say we need. And when we present the trial, we hope that we can say that we think we were powered enough to find an association if one existed. Because what this is the probability that you can conclude correctly that the treatments really did differ. So these are some, terminology that you should be familiar with. And if you are going to try and determine power for one of your studies, this is kind of like just a quick and dirty slide, but there's certain things that you would need to know in order to figure out whether or not you had enough power to get a reasonable result in your planned study. So the first thing is the difference in response rates to be detected. So do you want to be able to see a 50% drop in asthma attacks? That would be your difference you expect. You also need an estimate of the response rate in one of the groups. So you could say that I have a study that I just showed you that showed asthma rates in a control population. What were they? So say those were 75%. So in general, the percent of people that have an asthma attack in a population would be about 75%. I want my treatment to reduce it by 50%. So I want it to go down somewhere around 35%, 37%. So that's what number 1 and 2 is. Number 3 is easy. It's always 0.05. It's kind of like that's your no-brainer on the slide. And then the value of the power desired is 1 minus beta. And what did I say that should usually be at minimum? 80%, and then 90 or above is really ideal. And then the last thing is whether the test you're going to do in the end should be one-sided or two-sided. Does anyone know what this means? Yeah. Right, so a one-sided is like you think your treatment's going to be better. And two-sided is, I'm not really sure what's going to happen. And how big your sample size has to be is dependent in part on that decision as well. So that's your little power introduction. And now we're going to talk about crossover designs. A crossover in a study is any change of treatment for a patient in a clinical trial that involves a switch of study treatments. And there's two ways this occurs. One is a planned crossover. So this is that I've developed a protocol in advance, and the patient is going to serve as their own control. The other thing is unplanned crossovers. And sometimes these happen, and we don't want these to happen. We try and minimize these, where for different reasons people ask to change the treatment and don't want to stay in the one that they were randomized to. So planned crossover, each patient is his or her own control. It's important that you have a period for washout in between the two treatment groups so that there's no residual effect of the first treatment you gave someone before you give the second one. And sometimes what you want to do is change the order of assignment. Say you have treatments A and B, you might give A to the first person and B is the next thing they'll get. But the second person comes in, they get B first and then A. And just switch that up so that you're not always looking at one treatment following another treatment. So this is showing a new treatment here in the yellow versus a current treatment. So they get one or the other. They're randomized to this. So you observe and you measure the effects while they're in group 1 or in group 2. And then what happens, okay, I've already measured that. I'm going to wait, allow a little washout here, and then I'm going to say, okay, this person that previously got group 1 treatment is now getting group 2, and this person that previously got group 2 is now getting group 1. And we're going to follow them forward in time, and we're going to see whether or not there was any effect of these treatment. So in essence, each of these persons are serving as their own control. Like group 1 might be placebo, group 2 might be the active treatment. So every individual is getting both the active treatment and the control, or the old treatment and the new treatment. And but the important thing here is to always have that period of washout in between this transfer here where they go from group 1 to being in group 2, this block of people. And what I had said before is what's shown on this other side, that sometimes you want to start with group 1 and other times you want to start with group 2. You don't always want to start with the same treatment in the beginning. And then you end up comparing the group 1 treatment to the group 2 treatment, and it's great because everybody basically is matched to themselves, kind of in essence. So that's planned crossover. Now let's think about unplanned crossover. So ideally, we take our eligible population, we say, okay, we're going to randomize you. All of you are going to get surgery, and all of you are going to get medical treatment. And it would be great if that's how the study ended, and we went forward in time. But that's not reality. So in reality, you randomize them to surgery, and they say, no way am I having surgery. They refuse. And then people are in the medical treatment only, but then for some reason they require surgery, and they end up going here. So this is an issue. And this is unplanned crossover. So basically people are always constantly changing into which group they are in. So when I talked about intention to treat, this is where you think carefully about what that really means. So when we do intention to treat, there's going to be the people that had surgical treatment that were all randomized. The blue is always going to be analyzed against the yellow. So even though they're going to fall into these parts, in the end, we want to analyze them as if they stayed together the whole time. So intention to treat means that regardless of what they do in the study, if they were in the surgical group to begin with, they get analyzed in the surgical group, even if they change. And if they started in the medical group, they stay there, even if they changed and no longer, and even if they went on to surgery. because you randomize to this group or to this group. And as soon as you start mixing them up and putting them together in different ways, you lose that randomization. So they will no longer be equivalent between the two groups. So that's unplanned crossover. So there's another type of design that we do in randomized controlled trials, and this is factorial design. So if you assume that 2 drugs or 2 nutrients are to be tested, the outcomes that you expect for each one are different, and you think that the modes of action are independent, like they're not, one isn't going to impact the other. You can use the same population to test for both drugs at the same time. So it's a cost savings event, again, because these trials can be very expensive. So that's just shown here. So you have either treatment A or treatment B. This group of people are getting both treatment A and treatment B. This is getting neither A or B. This is getting only B, and this is getting only A, because it's positive up here, so this is A only. It's positive here, so this is B only. So what happens is you can look at the effect of treatment A versus no treatment, or treatment B versus no treatment, because basically we don't think A is impacting B. So we can either look at treatment A, where everything is positive here, treatment A versus treatment B. Or we could look at treatment B, and it would be the yellow boxes versus the white boxes. So in the same group of people, we basically get 2 studies for the price of 1. And this can be done if you don't think that treatment A and treatment B are influencing each other. So this is a real trial that was done that was a factorial trial. They started with 22,000 people, and they were randomized either to an aspirin or to placebo. And then they were further randomized to get beta-carotene or placebo. And so these people, 22,000, are getting a combination of aspirin or placebo and beta-carotene or placebo. And you could take all of those and put them into that 4-fold table of A, B, C, D. So this is what happens. You have these people that are getting both aspirin and beta-carotene, neither aspirin or beta-carotene, and here's aspirin alone, and here's beta-carotene alone. There's no reason to think that aspirin influences the effect of beta-carotene or vice versa, so you can do this trial and you can look at the outcomes. So that's what the 4-fold table would look like, and this is what the analysis would look like. So in this side here, when you have the blue versus the white, what treatment are you evaluating? That's aspirin, right? And then over here, you've got the beta-carotene. The yellow versus the white is the beta-carotene. So again, the same population, but you can actually look at 2 different answers to 2 different questions using the same population. So one of the issues is noncompliance. There's a lot of people who will agree to randomization, but they don't comply with the assigned treatment. We hope that they're telling the truth when they tell us how good their compliance was, but compliance is a big issue. So this was the drug I had talked about. This is a coronary drug project, and clofebrate was used to lower serum cholesterol levels. And here you had clofebrate, mortality 18.2, and placebo 19.4%. So do you think that this drug works at all? No, I heard. So it doesn't look like there's any difference. The drug doesn't appear to work. There's no change in the mortality rate. So the question is this really just a failed drug? We did all these other tests in advance. We thought it would work. Why did it not work? And so if we go on to the next thing, we see that noncompliance could have a real impact on those results. And in effect, there was poor compliance here was listed as less than 80%. There was almost 350 people were in that group, and then good compliance had 708. And if you look at the mortality rate, you see that poor compliance had the highest mortality rate, good compliance had a little lower, and they really averaged together to end up with the same effect as the placebo. So you had a better result in the compliers, but can you analyze the data looking at compliers versus the placebo group? Is that okay to do? So I saw a shake a head or 2. Why not? you want to do intent to treat, and why do you need to do that? What is the problem here if you look at the good compliers versus the placebo? Right, you lose all that randomization. You're introducing confounders, because what makes a person a good complier? It's all those healthy behaviors that maybe also change their mortality rate. So compliance is a big issue. Another thing that we look at in studies is efficacy. This is for a vaccine, how you would assess efficacy. It would be the rate in those who receive placebo, the rate of the disease that you have your vaccine against, and the rate in those who receive the vaccine. You subtract that out, divided by the rate in those who receive placebo. So this could be for placebo versus vaccine. It could be for placebo versus a nutrient or a drug or anything. That would be the efficacy. So here is a hypothetical study where we had 6 people. They were analyzed by the Kaplan-Meier test, and you've probably seen this in some of your readings or whatever. It's a very popular statistic. And in a randomized controlled trial or a cohort study where you have different lengths of follow-up, look at all these different lengths of follow-up. They either died or were lost to follow-up at totally different periods in just 6 people. This is of concern. So what happened to these dropouts? So how long was it between the time to death from the starting treatment in months in each of these 4 people that we showed over here that had died? So we have 4 deaths there. One occurred at 4 months, one at 10, one at 14, and one at 24. And typically, you're not going to see a table like this, but instead, you'll see a chart like this. And this is a typical presentation of results for a randomized controlled trial, where you have, this is the person that died at 4 months, because this is percent surviving. So at 4 months, you had one person die here. At 10 months, you had another one. At 14, another. And at 24, another. And so you end up down here with about, 45 or 50% that are still surviving. And that's what the statistic kind of does, dummy down a bit. But that's what the survival curve is looking at. One of the other measurements that we sometimes use in order to say, is it really worthwhile doing this? What is the number needed to treat in order to stop an event? This is oftentimes calculated, and it's 1 divided by the rate in untreated minus the rate in the treated group. So if the mortality rate in the untreated group was 17 and the mortality rate in the treated group was 12, then it says we need 20 people in order to prevent 1 death. And so if you say, okay, well, the cost of the drug is, X dollars. If it's, $10,000, you might think twice. If it's like $20, you might say it's ridiculous not to give this to everybody. And that's what comes into play with the number needed to treat. So the last analysis I did where we looked at this was for vitamin D to prevent falls, and it was 1 in 5. So for every 5 people you treated with vitamin D, you might prevent 1 fall. So given the low cost of vitamin D and given that statistic, it seems like it might be a reasonable thing to do, but there has been some pushback on that, and you'll hear more about that in the spring. So the Mr. Fit study was a huge intervention study from a while ago where they looked at hypertension treatments, they did intensive counseling and education about lifestyle changes, and they used usual care as the comparison group. And what happened with Mr. Fit is shown here. So here's the usual care, the UC, and then the intervention group is SI. So if you look at diastolic blood pressure, serum cholesterol, cigarette smoking, does it appear that this intervention appeared to work in terms of looking at these outcomes? Now that you understand a little bit about the curves, is it a beneficial thing to have the special intervention versus usual care? Yeah, you're getting what? What are you getting? You're getting a reduction in what? Blood pressure, cholesterol, smoking, right? All of these. So it's great. So was our trial a success? Yeah, it looks like it. So then you go on and you say, well, what we really care about is mortality. What difference does it make if all of these intermediate measures look better if in the end we don't get any benefit to mortality? And in reality, when you look at the mortality here, you can see that if it's really unclear whether there's success, because in reality, it's hard to see whether mortality changed between these two groups. All of these risk factors went down. But in the end, what we want to see is a true clinical endpoint change. And because of data like this and in trials like this, the FDA has gotten much more picky about drug trials, and what they want to see is not these intermediate endpoints, but they want to see the actual clinical endpoints like death or disease measurements, not just intermediates. So there's different phases of clinical trials. This one is specific for AIDS. Before a vaccine, drug, or treatment can be licensed for use, it needs to go through a lot of stages of development. And it really helps to protect the public, but at the same time, the delays will really avoid giving the people that need pharmaceutical help, they're not getting it. So critically ill patients, like people with AIDS or cancer, have to wait for these clinical trial results to finish. And, I'm sure that this will be a big issue when they come out with something for Ebola, because they're going to be like, okay, well, there's a huge need for this. We haven't done all the trials, but maybe we need to put it into place sooner. And every now and then where there's a huge public health issue, that will happen. But typically, there's a pretty long process that we go through. So this is the process for vaccines. First, they do phase 1 tests. They look at the vaccine in adult volunteers, and it doesn't need to be a lot of people, just to make sure nothing weird happens to those people. And phase 2, it expands the testing to 100 to 200 subjects. And then phase 3 is really the pivotal or the final trials that typically get published in New England Journal and stuff, where it assesses the efficacy of the vaccine in the target population. In other words, if you're going to use it in children, test it in children, and how well does it prevent disease. So that would be for a vaccine. And this is for new medicines, and I've been involved in a lot of these from phase 1 through phase 4. And the first phase is clinical pharmacology. Small number of people, just look for toxicology and some maybe intermediate points of efficacy. Then you look at relative safety and efficacy in a slightly larger trial. And here the phase 3 is a large-scale randomized controlled trial for effectiveness and safety. And by FDA mandates, typically this is looking at a clinical endpoint. Like for osteoporosis, we can't look at bone density. We have to look at fractures. The fracture has to be the endpoint. And then phase 4 is post-marketing surveillance, where you have to keep looking at your drug and see if any weird side effects crop up. And there's been a lot of that in the media lately as well, and that will continue to happen for different drugs. Yes?
How long does each phase normally last?
So phase 1 and 2 are typically shorter trials, so they might be only like months or up to a year, say, of treatment. They're not really long, but you might allow like 2 years to recruit everybody. Then when you get to phase 3, typically you're involving about 2 years of recruitment and then maybe 3 years of follow-up. And then, the data analysis. So that's why if you have a drug that you think might help, or maybe it's only promising in animals, it's a long time before you're going to get that drug into the market. Because then once you have your phase 3 trial, it might be published in the New England Journal, but you have to put that application into the FDA, and then it could be 9 months before you find out if it's approved, or they might say, you know what, we want some further data, and then you go back and collect that. And, so it can be, in general, about a 10-year process. And that's why they try and have the patents or whatever for the drugs last like 7 years to 10 years, because they know the investment of the company is so long to get the trial done and put the thing out in the market. Was there another question?
In regards to post-marketing surveillance, how long is that, though?
That's pretty much until it goes off patent.
All patent.
Yeah, it's typically the responsibility, that's what they hope the company that marketed it will do until it goes off patent. And if something happens, then it goes on even longer. So like Vioxx was a prime example where that was a great drug. It worked great as an anti-inflammatory agent, but then they found cardiac issues with that. And if they didn't do post-marketing surveillance, they maybe would have never seen it. And part of the problem is that phase 3 is usually really healthy people. Like you have all these exclusion criteria because you don't want to have people in a trial and have them die. or get really sick. So phase 3 trials are typically more healthy people than the general population. So you're testing a product there, and then it's going into the general population, and then maybe you'll find that if anyone had risk for heart disease plus they took Vioxx, then they were the ones that were getting the heart attacks, but you didn't know it because they were excluded from phase 3. So post-marketing surveillance lasts quite a while, and if you find anything, then it has to go on a little bit longer, and then it doesn't end, really. Even when it goes off patent, I think oftentimes, like there's one drug, alendronate, that Merck had done, and that was off patent maybe 6 years ago, and they're still following up cases of a lot of these things, in part because of legal action.
How long has this whole process been? How long have you been putting drugs through phase?
Through all these phases, it's at least 20 years. I mean, as long as I've known, they've been doing it, as long as I've been doing clinical research, and what's changed most is the phase 3 trials. The phase 1 and 2, they don't care that much about. The phase 3 and the phase 4 have gotten a little bit more picky. So phase 3 now, as I said, they've changed clinical endpoints only within like the past maybe 8 years or so. And then phase 4, now actually the FDA, if they see something is making people go back and do little studies to show that it's not going to cause some kind of an ill effect. So, it's gotten a little bit more involved in terms of the phase 3 and phase 4. Okay, so you have your reference population, then you have your study population. How different these two are impacts your generalizability or your external validity. So you want to make this reflect the general population, but you also want to make sure that you have a population at risk for some kind of outcome that you're going to follow later. So it's kind of a balancing act between the two. Then you randomize people to the new treatment or the current treatment, and if there's any bias or any confounders, that's internal validity that happens here. And that's what we always want to watch out for is confounding, get rid of it by doing randomization, blinding to get rid of any other bias. So that's why the randomized controlled trial really helps to alleviate most of the bias that we can see and confounding in other study designs. So there are ethical considerations. Is randomization ethical? Yeah, because we don't really know if the treatment will work or not at the point in time we're doing the study. And also, it's got to be randomization, or we may use ineffective treatments on patients. People might say, well, I want to get the active drug. Well, what if it doesn't work? We won't know if we only give everybody the active treatment. Another issue is, can the patient really provide informed consent? And this is a big issue now. I just did a consent form yesterday, and it was 15 pages. It's supposed to be 6th grade English, and you're supposed to have people understand all of it. And as the studies get bigger and more complicated and you have to put more risks in there, it's become like a novel they have to read in order to give consent. So I think this is going to come up as a bigger issue. One thing is that when you do it, you have to put it in 6th grade, it's either 6th or 8th grade English. So if you're using a bigger word, you have to parenthetically say, what does that mean in 8th grade English? So these are big issues. Then also, should a trial be stopped earlier than originally planned? And this will happen with something called a data safety monitoring board. So I chair like 2 of them, and I have to report data to 3 of them for trials that I do. And I'm constantly involved with the concept of a data safety monitoring board. And the concept of this is that you're doing a trial, you're plugging along, and you think everything's going well, but someone has to be evaluating whether there is any risk. In order to get funded, you had to show that you didn't think there was any risk, but we really don't know until we do the trial. So the biggest trial where it was stopped early was the Women's Health Initiative. Have you read that in Shaker's class or in the readings at all? The Women's Health Initiative. So that was a huge, huge trial. It was the biggest trial in my life that's ever been funded. And they had like 60,000 women randomized to hormone therapy versus not. They had dietary modification, which is part of your reading today. They had all kinds of trials combined into one, calcium and vitamin D trial. And after 6.5 years, it was stopped early because they had thought that estrogen would protect against a whole lot of diseases as compared to placebo. But the Data Safety Monitoring Board started to see a huge difference between the two groups. They didn't know yet which the groups were, but they felt that it was time to kind of unblind and see what we're looking at. And they felt that the risk for people to continue in that study was higher than the benefit of continuing the study. So they basically stopped the study early. And the other thing that's coming up now is whether we should be using a placebo or an active treatment. You know, we know now that we have a lot of treatments. When I first started in osteoporosis drugs, like 25 years ago, I first did my first trial in that, there wasn't anything. We had absolutely no drugs. Now we have a lot of them. And so as we go on to test the new ones, should they be tested against a placebo or should they be tested against another drug? The problem is you're always looking at that difference in effect. Remember I told you for the power of a study? So if you're looking at two drugs, that difference of effect is getting smaller and smaller as compared to a placebo versus a drug. So over time, we're going to see more discussion probably about that as we get more and more drugs down the pipeline. In general, whenever you do a study, you have to show the Institutional Review Board that your benefits outweigh the risks. You have to make sure that everybody provides informed consent. You can't withhold treatment from people if they want it and they want to leave the study. They are allowed to do so. No one needs to stay in the study. In some cases, if you're concerned about putting people on a placebo, like for my pelvic fracture healing trial, I'm going to only treat them 3 months with placebo versus the active drug, and then I'm going to look at whether the fracture heals. I'm going to see if they can perform better. Again, a clinical outcome. Can they walk faster? Can they get up from a chair better? And then after that, I'm offering everyone treatment. And that's how I avoid the problem of people had a fracture, they needed to be treated, but I'm saying, well, they are getting treatment. I'm just holding it back 3 months. And so that's one way you can do it with a sequential design like that. Everybody needs to be monitored for side effects. Sometimes this has already been tested in animals beforehand and we have an idea, but no animal model is a good model for what human experience will be. And so we really need to monitor for side effects very clearly. We have to think about when are we going to withdraw a patient. There's typically safety rules for us when we do a drug trial. We look at percent of bone loss, and if it exceeds 7%, then we offer them to leave the trial. Or if they have an event we think might be related to the drug, they get offered to leave the trial. And at all times, you always have to protect the interests of the patients. So some of the strengths of clinical trials, they really provide the greatest control over what the exposure is. We don't have to measure what people eat in their diet in terms of vitamin D or calcium. We can give them the pill and know exactly what they got. We know the exact timing and frequency of exposure, and we have a set period of observation. And because we randomize, we get rid of those group differences in the table 1. The limitations are that it's basically an artificial setting. We're not sure really what the potential impact will be after we finish our trial. Like when we put it into a real-world setting, will we get the same benefit? It's hard to make sure people adhere to the protocol, including compliance with the medicine. And then there's the ethical dilemmas that we just talked a little bit about. So I just want to give you a few slides on community trials before we do the readings. So community intervention trials determine the potential benefit of new policies and programs. The intervention can be any program or other planned effort designed to produce changes in the target population. And the community here is the unit that we're looking at. So we're looking at an intervention on the basis of county by county, state by state, school district by school district, community by community, as in the fluoride treatment. So we start these trials by determining what are the communities that are eligible and are willing to participate in what we want to do. We get baseline measures of the problem to be addressed. And then we use a lot of measures in the end, like disease rates, knowledge, attitudes, practices. Anything like that can be the outcome of a clinical trial in a community. So the communities are randomized, they're followed over time, and then we look at the outcomes of interest. So one of the advantages is that they really represent the only way to estimate directly the impact of a change in behavior or modifiable exposure on the incidence of disease in like a whole population, as opposed to a clinical trial where you have people that are specifically entering that trial might be different from other individuals. So this is a way of really looking at things in the community, which is where any interventions would eventually take place. But there's several disadvantages. It's harder to control entrance into the study. It's harder to make sure everyone is actually getting the intervention. And it's harder to monitor the outcomes. It's not like you have Mrs. Smith and Mrs. Jones that are taking different trips into your clinical center and you're evaluating them. Instead, you have whole school districts, say, that were randomized to different phys ed programs, and you're asking them to report data at that level. Because there's fewer study units, say if you're doing it school district by school district, there's fewer of them that are randomized, so therefore getting rid of the differences might be harder to do. Just like in a smaller study, it's harder to make that table 1 be equal between the two groups. And also there's a lot of things that influence these trials that you have no control on. Population dynamics, any changes over time that a trend or that occur over time, these secular trends, and anything other than your intervention that might be going on simultaneously that you don't know about. So you might be trying to look at phys ed, and you didn't realize that at the same time all of the classrooms were instituting movement in math and movement in English and movement in whatever class they're teaching, and so that's going to be harder to control. Okay, so I had 2 pages.